Welcome everyone to today's webinar. I am Emily Rapley, Assistant Editor with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Dr. Haitham Gurir currently serves as the Medical Director of Medical Affairs at Olympus Corporation of the Americas. Dr. Gurir has over 10 years of international training and work experience in surgery, research, academia, and business administration. Prior to his role at Olympus Corporation of the Americas, Dr. Gurir was a PhD Fellow at the University of Verona in Verona, Italy. He also studied in Tokyo, Japan, and Cairo, Egypt, with clinical fellowships in minimally invasive surgery and surgical oncology, respectively. Dr. Haitham Gurir received his PhD of Surgical Oncology, Bachelor of Medicine, and Bachelor of Surgery degree from the Cairo University in Cairo, Egypt. He also received his Master's of Business Administration from Holt International Business School in Boston, Massachusetts. Haitham, I'll now turn the floor over to you.
Thank you very much, Emily, and thank you all for participating in this webinar. Hopefully, we'll provide you with some interesting facts and information that you will find valuable in the next hour or so. So I will just go ahead and get started with my first slide. It's the disclaimer, and I'll just briefly touch on what we're going to discuss today. So the point here is that we want to highlight some of the most common, complicated, and costly procedures, and really identify how your facilities can potentially avoid about $30,000 in additional costs per patient if complications related to those procedures, those common procedures, can be avoided. It's all about using a very simple technique, which is intraoperative endoscopy, to avoid those complications. And really, this small technique would have a significant impact. And we'll also touch briefly on the value-based programs that relate to this value. So to start off, I just wanted to highlight the triple aim. We're all familiar with the triple aim, and we all know as individuals or facilities or organizations that contribute to the healthcare system, we are all about better costs, lower costs, better patient care, and better health and better outcomes in the entirety of what we offer. In that, we look at fewer complications, shorter length of stay, reduced readmission rates, cost savings related to how the procedure is performed, and mitigating the complications and risks associated with it. Again, overall, the idea is to better care, better cost, and lower cost, and better healthcare outcomes. So what are those most common, complicated, and costly procedures? Intestinal obstruction, perforated bowel, abdominal trauma, benign and malignant diseases of the bowel are really very common surgical procedures that we encounter day to day in surgical practice and in our institutions. Usually they must be treated operatively, and frequently they would require some form of resection and anastomosis. And really, the good outcome of these procedures is the successful healing of the anastomosis. There are factors that relate to how well the anastomosis would heal, or the risk factors associated with that are really a variety of things. But just to highlight a few, there are systemic factors depending on how well the patient is nourished. There are local factors depending on how the peritoneal cavity or the operative field was. But more importantly is the actual surgical technique, and it's all about ensuring that the anastomosis is tension-free with good blood supply at the time of the procedure. But as you can see here from the screen, that the most common procedures that actually are involved in some form of resection and anastomosis are the small bowel, the colorectal resections, and gastrectomy. They are also associated with significant readmission rates, and we'll talk about that in a few minutes. And like I said, they are common, and these procedures have one thing in common. It is about the anastomosis, right? And from studies that have been published out that date back to 1973, it has been known that postoperative leaks or dehiscence of the anastomosis can lead to 1/5 or up to 1/3 of postoperative deaths related to these procedures. But it's not only just the the leak, but it's also long-term complications that may be associated with the leak itself. Things like strictures, narrowing of the anastomosis, a drainage tract that would form into the skin with known as an external fistulas. Also, there's a chance that pneumonia would occur as another more dangerous complication that compounds the risk or adds on to the risks of a anastomotic leak. Pneumonia would likely occur when digestive juices can spill into the lung cavity. So what's really the magnitude of the problem? It has been reported that anastomotic leaks are a very common complication, and they tend to range from 1.5 to 16% globally. The definitions vary, but this is the accepted rates are usually also vary quite a bit and can range up to 16%. It has been recognized that between two surgeons, the rates of anastomotic leaks can vary quite a bit, significantly, up to a factor of 60. And it's all about being able to detect the anastomosis early as part of a standard procedure, that this complication can be avoided. And it's very important to recognize that, as we mentioned, there are other factors that relate to the anastomosis. It's the anastomosis failure or the leak. That although the rate is increasingly been constant over the past 30 years, there is an aging population out there, and because of the aging population, the systemic factors and comorbidities related to patient well nourishment can actually compound or increase the risk of anastomotic leaks. This is another thing to add to the magnitude of the problem. Speaking specifically to colorectal surgery, I have some citations here from recent studies. One actually quoted that there's an increased total clinical and economic burden of about 60 to 190% for 30-day readmission rates. It will also incorporate post-operative infection rates, which are greatly increased and would compound or add on to the mortality rates that would reach up to 32%. In addition to that, not only are the rates increased, but there's also an impact on the quality of care and patient experience. So if a permanent stoma, which can be done as a result of the failed anastomosis entirely and not being able to reconnect or rejoin the ends, this would heavily impact the quality of care, the experience of the patient, and definitely would have a strong outcome on the outcomes and healthcare implications of the procedure. Moving on to bariatric surgery, it's also been affected by anastomotic leaks, and one very common procedure is the Roux-en-Y gastric bypass. One study quoted that as an independent factor, a very strong independent factor of postoperative death is actually anastomotic leaks related to those procedures. It is a dreaded and potentially devastating complication with a mortality rate of nearly 50% if not identified, diagnosed, and treated early on. So this is an interesting graph. We wanted to. This is actually a quote from a study that was recently published in 2014. They have assessed the rates of postoperative infection, 30-day readmission, and total length of stay for about 6,170 patients, and they looked at what the costs would be, or the rates of those rates would be, and eventually cost impact of those elements would be on patients or in the healthcare system with anastomotic leaks and without anastomotic leaks. So when you look at the slide, you can see that when you do not have an anastomotic leak, which is clearly seen on the left side of the screen, you will have lower post-operative infection rates, less readmissions, and a shorter length of stay. Those numbers would leap significantly when you have an anastomotic leak, as you can see on the right. Infection rates would triple, readmissions would double, and the total length of stay would increase by almost 10 days. So that same study also highlighted that the added length of stay is a primary driver of costs. You can see length of stay alone makes up over half of the total average costs. For every leak you may have, you are losing around $30,000, and this is just, I'm going to actually quote from the study itself in the paper. So they had a sentence in there that for every 1,000 patients undergoing colorectal surgery, the economic burden for anastomotic leaks, including hospitalization and readmission, would be 9,500 days in prolonged length of stay and $2.8 million in additional costs. So in summary, here's just a recap of some of the figures we threw out there. As you can see that anastomotic leak can potentially double your length of stay and increase costs by $30,000. Mortality, including wound infection and mortality rates, would increase exponentially, with mortality rates reaching up to 30%. And that's an important added cost, because death is still very expensive to the hospital. Death is reported to be 2.7 times more expensive to patients who undergo a procedure compared to those that survive and those that suffer from mortality. So how can we avoid these complications and continue to reduce costs on your facilities? The truth is, anastomotic leaks can be reduced, and good outcome would depend on, like we mentioned, the successful healing of the anastomosis. The idea is to diagnose it early, because once they are diagnosed late or the diagnosis is missed and patients are discharged from the hospital, there's a chance that they will come back for readmission, and those some of the rates that we mentioned earlier relating to those very complicated procedure. Early detection is the key, and as long as it's part of a standardized approach, one that can be repeated and becomes part of a practice where surgeons are familiar on when and how to do this procedure, it will make it will contribute significantly in decreasing the rates of anastomotic leaks. So what we're trying to share with you here today, that the visualization plays an important part on promoting those better outcomes with these procedures. There are really two main categories of how outcomes can be improved, or the risk decreased for an anastomotic leak. One is at the time of performing the anastomosis, and it's the surgical technique itself, by adequately mobilizing the bowel, ensuring that the ends are viable when we were connecting the GI tract, and ensuring that the ends or the bowel itself is tension-free without twist. But like we mentioned, it tends to vary. It's not necessarily a mistake of a surgeon. They tend to happen, and they tend to be missed for a variety of factors. So while we're in the OR, while we're performing the procedure, it's always routine to assess the anastomosis intraoperatively, and some of the techniques that are used are methylene blue testing, endoscopic evaluation with air leak test, amongst others. But the impact of intraoperative endoscopy, what it really does is that it allows the visualization of the entire lumen of the GI during the procedure, ensuring that it's sound. So it does play, intraoperative endoscopy does play a fundamental role in decreasing the risks of an anastomotic leak. So like I mentioned, what it really does, it enables the surgeon to visualize the internal part or interluminal part of the GI tract. It not only allows the assessment of the anastomosis itself, but sometimes there's bleeding that's likely to be missed at the site of the anastomosis. This allows evaluating that, as well as the patency of the actual tract itself after it's been re-anastomosed or reconnected. But also, if we're doing a laparoscopic procedure, it becomes a combined visualization. You can visualize the bowel itself externally and internally as well. And the true value is that while you're there in the OR and you do realize that there's something wrong with the anastomosis, you're able to correct it on table, so right there. So again, this is part of the cost savings, part of really it's part of the experience, the patient experience. If they are discharged from the OR and it does happen that an anastomotic leak does occur or was missed, it is likely that in most cases there might be readmission and there might likely be a reoperative procedure. So there have been studies that specifically highlighted the role and advantages of intraoperative endoscopy. One study actually reported that a zero leak after using intraoperative endoscopy routinely in 290 patients. Another study that actually was more extensive than that looked at the medical records of 2,300 patients who had undergone a Roux-en-Y gastric bypass for a period of 9 years. And what they concluded was that routine intraoperative use allowed the reduction of potential leak rate by close to 92% compared to no testing. And all it's 5 to 10 minutes on average added time to the procedure. But as you can see, it relatively does affect the morbidity rate and the mortality rate, where it actually concluded that the morbidity rate decreased from 3.2% to 1.3%. This is another slide that actually looks at 3 different studies that looked into the decreased rates, anastomotic leak rates with intraoperative endoscopy use. The first study actually highlighted that there were no post-operative leaks in 340 patients because even though there were 56 leaks found and corrected during the post-operative, intraoperative procedure by using IOE. This, if we look at the numbers we discussed earlier, the 28,000, this actually comes down to a savings of about $1.6 million. Champion et al. Looked at 825 laparoscopic bariatric procedures. All had intraoperative endoscopy performed during the procedure. The rates, the anastomotic leak rates went down from 3.8 to 0.4%. Aladeen et al. Published a study of 400 patients that found that IOE reduced postoperative leaks from 4 to 0.5% as well. If we do a quick look at the numbers really quickly, and if we look at the total cost savings of $28,000 per patient, looking at these studies specifically, you can see that there's almost about $3 million in savings by using intraoperative endoscopy routinely with those bariatric procedures, or with that one bariatric procedure. So what is the true value of this? We can look at things that are actually related to quality and quality reporting systems. So the physician quality reporting system, I'm sure most of you are familiar with, that is now required by Medicare, requires reporting on 9 or more measures that cover at least 3 national quality strategy domains. 3 very important quality metrics that are included in 2016 measures relate to anastomotic leaks in some way or form, and so reporting on those outcomes can potentially be something that is very important to an institution. We also know that the physician quality reporting system is turning into the merit-based incentive payment system program in the future, and so which would require more emphasis on the value-based healthcare offered. This is really part of the bigger emphasis or bigger value brought about by decreasing intraoperative leaks, or ensuring that there's a quality metric system to highlight the decrease or ways of decreasing the rates of anastomotic leaks. So as you can see from this graph as well, avoiding penalties and associated costs with leaks, from 2015 to 2018, there has been an increasing percentage of Medicare payments tied to quality or value. And as we know, this will continue to be a focus in healthcare moving forward into the future. Numerous initiatives have shown that taking steps to reduce one type of infection or lower readmissions for patients with a particular condition seems to give facilities the most bang for their buck as they begin navigating through the world of value-based reimbursement. And I really like this quote. I decided in my last slide. This really sums it all. It's from a book on techniques in gastrointestinal endoscopy, and it basically highlights the value of intraoperative endoscopy. It clearly states that it adds value in the operating room and adds the promise of improved significant surgical outcomes by providing useful clinical information important to the point of service decision-making that allows surgeons to address technical concerns before they manifest as post-operative complications. So you're there you're in the procedure, and if you're able to recognize on table that there's a complication or a risk of a complication recurring in the post-operative period, you're able to correct it. You're able to anticipate the risk, and so eventually it adds up to what we talked about with better outcomes, decreased costs, and a better experience for the patient, so better healthcare results. Finally, in summary, just as a quick recap, that resection anastomosis is a common part of a lot of surgical procedures, some of the common surgical procedures, and one complication is the anastomotic leak, which tends to vary globally from 1.5 to 16%. The success or the best outcomes can be achieved when doing these procedures by ensuring that the intestinal anastomosis is intact. When we discussed how intraoperative endoscopy can have an impact on these rates, in addition to the surgical technique. And one figure that we quoted from the recent study by Hammond et al. Was that there's about $28,000 per patient cost reduction if we're able to diagnose and detect early anastomotic leaks. Thank you.
Thank you, Haitham. That was a fantastic presentation. We will now open the floor to our audience to ask questions. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we can. So for our first question, Haitham, you mentioned that anastomotic leaks can increase costs by about $28,000 per patient on average. Where does that $28,000 come from?
So as mentioned, this was a recent study in the Journal of Gastrointestinal Surgery in 2014. They looked at the Premier Prospective database, which spanned from January 2018 to December 2010, and they basically analyzed the results of patients that underwent colorectal surgery and the results of whether they had the results with and without post-operative anastomotic leaks. And they found that the incurred additional costs with an anastomotic leak can increase the length of hospital stay to about 7.3 days, and this is where the figure came about, the $28,000. This is really related to hospitalization and all the other costs combined.
Got it. Thank you for clarifying that. So for our next question from the audience, is there any difference in an anastomotic leak between laparoscopic and open surgery? So no, actually, there is no difference. I think there's also a study there that mentioned that there might be a lower incidence in with laparoscopic surgery. However, overall there really is no difference in anastomotic leak between open and laparoscopic surgery. Thank you. Okay, so for our next question, we have an audience member who would like to know if there are any credentialing issues. Is it typical for a surgeon to be doing the endoscopy, or does a GI physician have to be part of the process?
There really isn't, no. I think it's intraoperative endoscopy is a procedure that's done by the surgeon. Like I said, as part of the procedure. It's done routinely. It's a lot of surgeons are now practicing this technique and doing it. They're adopting it more and more. So there are really no credentialing issues. It's again, there's no immediate intervention with the endoscope. It's just visualization and detection at an early stage. So none necessary.
Thanks for clarifying that. So for our next question, this is about equipment needs and staffing. Could you discuss a little more the upfront equipment needs, and is additional staffing needed? Are OR staff trained to support IOE?
So no, it will require a standard endoscopy tower and the scope. Nothing more beyond that. Additional staffing, no. I mean, the intraoperative nurse can also be educated in the safe and effective use of the tower and be able to support the use of the scope during a procedure. There really is no requirement other than that. So if everyone in the OR is trained on how to use it and is able to adapt to the tower being present in the OR, there's nothing more that's needed beyond that in most cases.
Sure, that makes a lot of sense. Thank you. So for our next question, how is IOE performed for colorectal and bariatric procedures?
Yeah, so it's a little different. For a colorectal procedure, they would be using a colonoscope. They will use the colonoscope to visualize the anastomosis in the colon, and it's pretty much more or less the same technique. They would look into the 4 quadrants of the anastomosis to ensure that there's nothing on the surface. There are no bleeding. There's nothing that is attached or that can cover up the stapler line or the and they would use, again, the same technique for a GI scope. They would do an air leak test in both cases as well, which would mean that they would seal off one end and then inflate with air and look for, after the cavity's been filled with fluid, they will look for air bubbles. But other than that, it's about visualizing and looking for the same elements, so which is the anastomosis intact. There's an airtight seal, and there is no bleeding at the site of the anastomosis.
Perfect. Thank you for clarifying that. So I'm just going to take a moment to remind our audience, if they have any questions for Dr. Greer, you can enter them into your control panel in the space labeled Enter a Question for Staff and clicking Send. So on to our next question. What are other procedures that can detect leaks in the OR, and what other ways can you detect leaks and treat in the OR?
So procedures specifically benefit from intraoperative endoscopy. There aren't any other common procedures that are different from colorectal and gastric Roux-en-Y reconnection procedures. There are other techniques that are used. So in addition to the air leak test and the colonoscopic visualization, there's the methylene blue leak test. There's also Doppler. There's a form of Doppler because it's all about blood flow and ensuring adequate perfusion to the ends of the anastomosis. There are laser Dopplers that have been used. In addition, there's also the near-infrared use to detect perfusion.
Perfect. Thank you for clarifying that. So for our next question from the audience, besides small bowel resection, colorectal resection, and gastrectomy, what other procedures may be affected by anastomotic leaks?
So there are procedures related to biliary reconstruction, and one very common procedure that is very common, in fact, is the laparoscopic cholecystectomy. But again, those procedures would not be directly impacted by the use of intraoperative endoscopy. There are other modalities to ensure that those leaks do not occur, but they would not be related specifically to intraoperative endoscopy.
Great, thank you. That's really helpful to understand. So we have an audience member who asked to review slide number 11. They'd like you to go over the numbers again and explain that a little bit more.
Okay, just a second. So slide number 11. So yeah, again, this is directly from a study that was published in 2014. They did look at anastomotic leaks, comparing, looking at over 6,000 procedures that were done over a period of 2 years, and they looked at the costs associated with the complications rates that were on slide 11. So they looked at the post-operative infection rates without anastomotic leaks and with anastomotic leaks, 30-day readmissions and total length of hospital stay. And they readjusted those rates after looking at univariate analysis and multivariate analysis, and they adjusted them to a score, a matching score that allowed them to calculate those values. And as you can see, there's a difference here directly from the numbers on the screen of about 28,000 between the total cost associated with those 3 elements, and in cases where an anastomotic leak occurred and when an anastomotic leak did not occur.
Perfect. Thank you so much for in a little more depth. So for our next question from an audience member, we have an audience member who would like to know, is there a change in reimbursement when using IOE versus traditional methods?
No, the reimbursement remains the same on the inpatient
Perfect.
side.
Thank you. Thank you so much for clarifying that. And as a reminder to our audience, you can enter any questions you have for Dr. Greer in the control panel in the space that says enter a question for staff and clicking send. We'll give our audience just a few minutes to let those filter in. Dr. Greer, we have another question from an audience member. Could you talk a little more about the patient impact if they do have an anastomotic leak?
So in most cases, if it's not detected early and it's missed, the patient could get discharged with the leak, and then they will come back and be readmitted because of the complications related to the leak. And the complications, as we mentioned, most commonly is infection, sepsis. Eventually, there's also, as we mentioned earlier in the presentation, there are things that can complicate further beyond the leak. Things like strictures, things like fistulae, things like, and eventually that would lead to the mortality. Also, we mentioned the stoma formation if the bowel ends were not reconnected properly because of all these complications compounded. So the idea is that early detection, ability to identify the risk, decrease that burden or that total cost on the healthcare system, on the institution, and affecting the quality of care of the patient. This is what we really cover when doing intraoperative endoscopy.
Perfect. Thank you so much for explaining that. So we have another question from the audience. What is the timeline for a leak to occur?
So it tends to vary, but usually within the first 30 days.
Okay, perfect. Thanks for clarifying that. We have a few more questions coming in from our audience. Is there any correlation with respect to gender or age?
No, so the gender per se, no. I think the factors, the systemic, there are systemic factors that do impact the anastomotic leaks. It's patients with lower immunity, patients that are diabetic, things that are related more to comorbidity that could be associated with age. So again, as we mentioned earlier in the presentation, with an aging population, the rates of comorbidities tends to increase, the immunity tends to weaken. Those are elements that do affect the healing process in general, and will definitely have an impact on the anastomosis healing capability, and thus a risk for increased leak.
That's really interesting. Thank you for clarifying that. I'll give our audience a few more moments. We have time for a couple more questions. Okay, perfect. It looks like those are all the questions we have today. I want to thank Hytham for his excellent presentation and to our audience for their participation. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you. Thank you very much. Thank you, Emily.